So good morning, good afternoon, and good evening to YPOers and friends around the world. I'm Dick Simon, chair of the YPO Psychedelic Medicine for Mental Health Group, and I'd like to welcome you. I've spent, for those new to the wait, let me just make sure, for some reason or another, where everyone should be muted. Great.
We can see. We can.
So for those new to these calls, I'm Dick Simon, and I've been a member of YPO for over 20 years now. For the past several years, I've been focusing all of my efforts on mental health and advancing the potential of psychedelic therapies through work with nonprofits, businesses, and research centers, including Mass General Hospital's new Center for the Neuroscience of Psychedelics. Working with Rachel, who you will hear from, who's creating a center, and many other people. Before starting, I just wanted to point out a couple of things. One, for those YPOers involved, YPOers and spouses involved, who are potentially interested, we're looking for additional volunteers in the leadership of this group to help with future global conference calls, chapter programs, and we're looking at implementing action forums as well as micro forums. So if you're interested in any of that, please let me know. And a disclaimer, we're absolutely, even though the topic here is around mental health and psychedelic medicines, we're absolutely not advocating the use of any illegal substances, and YPO does not take a position on this or any of the issues raised or said by anyone. So today's format is going to be a fireside chat followed by a Q&A. You want to use the chat function in Zoom to send me any of your questions, and they'll be queued up, and then we'll take them one at a time. So we're very grateful today to have Rachel Yehuda here. Rachel's a leading researcher in PTSD and has done pioneering research into the intergenerational epigenetic transmission of trauma in the children of Holocaust survivors. She's also the founder and chair of the Mount Sinai Psychedelic Research Center, professor and director of the Traumatic Stress Studies Division at Mount Sinai School of Medicine, and runs the Bronx Veterans Affairs Mental Health Department, or VA, where she's working with MAPS to bring MDMA-assisted therapy to veterans who are suffering from PTSD. She's authored more than 250 published papers. She's done chapters and books in the fields of traumatic stress and the neurobiology of PTSD. We had the chance to spend a week together at the World Economic Forum, and in addition to being a brilliant researcher and leader, as you'll hear, Rachel's an incredible human being who I'm honored to know, have tremendous admiration for, and consider a friend. Rachel, welcome, and thank you so much for being here.
Thank you for inviting me. It's a pleasure.
So, Rachel, could you start by telling us about the work that you've been involved with before you became interested in psychedelics?
Oh, sure. Since about 1988 or so, since my postdoctoral fellowship, really, I've been involved in studies of post-traumatic stress disorder. And in fact, our laboratory was among the very first laboratories to define what the biologic underpinnings of PTSD were, or are actually. And at the time that we started this work, PTSD, if you remember, was a controversial diagnosis. And there were really a lot of questions about it. The field was not openly accepting the idea of a prolonged response to trauma. Science didn't really have a paradigm for explaining how events that happened to us well in the past can continue to produce long-term effects and have the power of transformation. What science had at the time was fight or flight, which suggested an immediate response that kind of goes back to normal. So I became very engaged in this question of what is it about some events, or particularly traumatic events, that really create a transformational change. What does that look like in the body? And also this mystery that not everybody responds to trauma in the same way. This was another idea that was very difficult for psychiatry to understand. At the time that stress research was really gaining a lot of momentum, stress had effects that were universal. And that was easy to understand, what happens to people under stress. But the idea that only a percentage of persons exposed to various traumatic events would get PTSD, what was that about? So our lab really began to study this. In the beginning, it was hard. We focused on hormonal changes and brain changes. And somewhere along the line in the 2000s, we became acquainted with epigenetics as a concept that really we thought could explain a lot of what was happening in PTSD, especially in terms of this concept of enduring change and transformation. Our DNA does not change over the course of our lives. We're born with the genes that we're born with, but we change. So how does environment interact with our genes to cause those changes? And in the context, as you said, Dick, we bumped into this idea of intergenerational trauma. Not only do epigenetic concepts and mechanisms explain transformational change in people, it also explains potentially why these effects linger to the next generation. So the research has really developed. There are a lot of papers and things that we've written about it, to understanding not only how traumatic events change people and why some people change in different ways than others, but also how treatment and therapy also produce transformational change. So all of these are things that we have done in my lab.
Wow. So can you talk a little bit, as you became interested in psychedelics, how did some of your earlier work on the intergenerational trauma transfer inform your thinking about the potential of psychedelics?
Well, I mean, I can tell you how I got interested in psychedelics. It wasn't, it took a little work. When I first heard about psychedelics in PTSD, I wasn't wildly enthusiastic about the idea. I should say that. But I did have a few really critical educational experiences that kind of got me over to the side where I am now, which is that I think that there's unbelievable potential here with psychedelics in terms of treating PTSD, and particularly understanding some of the mechanisms through which psychedelics work really dovetail very nicely with our understanding of how transformation is made biologically and how people use traumatic or other lifetime experiences to change. Also, the idea that over the course of a more than 30-year career, I've been in contact with concepts that really challenged the zeitgeist and our mainstream understanding of things. And that happened way early. My very first biologic finding in PTSD was paradoxical and showed that stress hormone levels were actually lower in people with PTSD. So I'm very used to being open to new ways of looking at things. And so I think that all of the things that we have found that I think have some real impact were things that you couldn't initially have predicted. And I think the same is true with psychedelics. It's not something that you would have immediately predicted, especially coming from the 90s and the fact that, of course, psychedelics are not legal, certainly not in the United States. It's not the obvious thing. But I think as a scientist, you have to stay open to possibilities. And eventually, the way I became interested in psychedelics, when I first heard about it, of course, I first heard about MDMA-assisted psychotherapy for PTSD, and I immediately went to the literature to look at the effects of MDMA. And it seemed like a scary story. In the 1980s and 90s, the literature on MDMA suggested the potential of serotonergic neurotoxicity, brain damage. And of course, that is what neuroscience was saying. And it took a while until just recently where different kinds of studies are being done to kind of convey a different message.
Yeah. So why did you decide to focus on MDMA? And can you share with people a little bit about why MDA in particular is, or at least maybe, so effective at helping with PTSD in particular?
Well, I'll return back to when I was skeptical. A friend of mine had been invited to be a donor for a study site in Israel. And this was maybe going back 7 years ago. And she's the one that told me about MDMA's great potential for PTSD. And I had heard, I had seen case reports. I had heard that this was happening in the field. And I agreed to go with her to visit the site. And I think what I found very surprising when I went to visit was just how enthusiastic the therapists were about this treatment. And for some reason, maybe because scientists are naturally skeptical, the level of enthusiasm really cut me to a quick, and in a way where I felt like it was my job to be skeptical, because obviously the people doing the research were not skeptical. And the idea of the claim was, after one MDMA psychotherapy session, patients that they had studied that had had PTSD for years and decades, which is the way it works with chronic PTSD, no longer had PTSD, and said that they had been absolutely transformed. Now, you know, by this time, I had already been in the field a good 20 years, and I had seen a lot of people make a lot of claims about a lot of treatments. So my initial idea was, this is another claim being made. But you know, a couple years later, I actually met Rick Doblin, and he did something that kind of changed my life. He invited me to participate in the MAPS training, where I could spend quite an intensive amount of time, really 7 full days, immersed in learning about how exactly this works, and watching videos and being trained really by the masters, Annie and Michael Mithofer. And this experience really did help allay some of my suspicions, but more importantly, I understood that the claim wasn't that MDMA was curing PTSD. The claim was way more nuanced than that. It was that you need to be in a certain state of mind in order to process extremely traumatic events. And you need a certain kind of psychotherapy that is rather continuous and allows for what comes up naturally, particularly when you're in an optimum state to do trauma-focused work. So by the time the training that I did was over, I knew that even if we would never ourselves be able to give MDMA in the context of where I work, that I understood a lot more about psychotherapy for trauma. But then I thought, you know, I would like to really try to bring this to the VA and try to bring this to Mount Sinai. I knew it would be a heavy lift. As part of the therapist training, they offer therapists the experience of participating in a protocol with MDMA and 2 therapists, so that you get to have the experience that the patient will be having. And for me, I found it extraordinarily powerful and useful. And by the time that was done, which was sometime last year, almost 12 months ago, 14 months ago, maybe longer, I knew that this was something that I had to do. We have done many treatment trials, many clinical trials over the 30 years that I've been a researcher, trying to understand how everything works. And I've been mostly disappointed by the way that therapies work. But why I am very optimistic about this one is that it's not another incremental idea based on the same old philosophy, it actually represents a revolution in how you tackle the problem of trauma and how you deal with a trauma survivor. And I'm up for that. I think that our field needs it. And so I'm going to really, I'm all in. I'm going to really try to make it happen.
And you are the sort of person where when you're all in, things will happen. So could you talk a little bit about the scope of your work at the VA, at the Bronx VA, sort of giving people a context on your unique position to be looking at and talking about this and thinking about how institutions like the VA provide care for veterans and what that means within that context and even in a broader context?
Well, I wear several hats in my day job. The VA is affiliated with Mount Sinai. I'm a professor and actually vice chair of psychiatry at Mount Sinai. And I spend almost all of my time at the VA where I am director of mental health. So I'm expected to kind of run the organization of mental health, which it's a care center model. So there are about 200 employees, psychiatrists, psychologists, social workers, and nurses, and other allied professionals working together in groups. That there's a PTSD program, a substance abuse program, a geriatric program, little programs within the department. So I run that. But I'm also a researcher, and I have many grants that are designed to examine various aspects of PTSD. I have done quite a lot of work on the Holocaust and populations such as 9/11 and other groups. But I would say that maybe 75% of my portfolio is work on combat veterans and has been done at the VA. And right now, these include treatment trials. The kind of treatment trials we do are we examine how standard behavioral treatments work. The recommended treatment at the VA and other guidelines is cognitive behavioral therapy. It's supposedly the gold standard. I think almost everyone in the field would agree that it's more like a gold veneer standard. I mean, most people who have this kind of a therapy don't lose their diagnosis. They might get a little bit better. Some people actually get very triggered by it and actually get worse. I've seen that happen. But people do improve their symptoms with it, but it's kind of like a little bit of an improvement in symptoms without really taking away the main problem. But we have really wanted to study this. We want to be able to predict who responds to treatments, and we want to understand biologically what it looks like when people don't have PTSD anymore. That's really important, whether it's just an absence of the things we saw before or an activation of new mechanisms. And some of this biologic work needs to identify new targets. So if you find a biologic change that either predicts a response or changes in association with any therapy, you want to design a new therapy so that you're activating that target. And so we do some of that stuff. We do work in, I don't want to bore you, we do work in our laboratory that is also designed to look at risk factors. We have a model now where we're also trying to see whether the information that you get from blood cells is really informative about brain processes. So right now we have a very big effort where we take skin cells from combat veterans with and without PTSD. We regrow them into pluripotent stem cells, and then we grow neurons from those cells. And then we can study developmentally how those neurons respond in people with or without PTSD to stress hormone doses. So we can actually use that preparation to study the effects of psychedelics also. So we have a lot of things that we do. We like doing them, and veterans like to participate in our research because increasingly they understand that this work is directly beneficial to them. The VA has no trouble funding and promoting work on treatments that have been vetted and have been established as gold standard treatments. And they also have no trouble if you innovate a treatment, but they very much have a difficult time with the study of treatments that are Schedule I compounds. This is where it gets very difficult. And that's why the task of bringing MDMA-assisted psychotherapy into mainstream academic settings and certainly government settings is challenging.
So I'm thinking about all of our little brains in a dish that you're growing.
That's exactly what we call a brain in a dish.
Um,
Exactly, brain cells in a dish, though.
Brain is just a bunch of cells. Yeah. So
Yeah.
So what is your, going back to the MDMA in particular question. So if MDMA were part of the process, how might, combat veterans currently suffering from PTSD, how might that challenge look different in 5 or 10 years when this treatment might be generally available through the VA and elsewhere?
I mean, we have to do the work. It's obviously, I would say about any treatment, that if 68% of the people that had the treatment no longer had the diagnosis and no longer had the symptoms associated with the diagnosis, this would be a game changer everywhere. But you got to do the work. The VA is a setting where there are people there that have been symptomatic for a very long time. And many of them are in a status of disability and have multiple problems. So obviously it's very important to just do the work and see how it goes, and do the work as with all the safety measures possible. I think that one of the things that's very important now, and it's a very important feature of the center that we've started at Mount Sinai, is to try to educate people who are working with patients, especially PTSD patients, whether they're psychiatrists or psychologists or social workers, really trying to give them information about what psychedelic-assisted psychotherapy looks like. What is it? I think there are a lot of misconceptions about what it is, a lot of fears about what it is, and kind of in order to get into mainstream mental health treatment, you have to be able to learn about what it is. Currently, I don't know of any graduate school or medical school that is teaching psychedelic psychotherapy as part of its curriculum. One of the things we want to do at Mount Sinai is create a resident rotation, an elective in our program, so that it becomes just something that people learn very early on in their career and take for granted as just another tool out there. Of course, I think psychedelic-assisted psychotherapy is more than a tool, it's potential revolution, but I also think that you got to start with making sure people understand what it is and what it isn't.
Right. Actually, can I ask you to elaborate on that, what it isn't?
Well, again, I said it before, I think there's a very big difference in saying that psychedelics have the power to reverse mental health symptoms. The way that you prescribe an antidepressant, or the way that you prescribe another kind of a pharmacologic agent. The idea there is that the medicine is going to reduce the symptoms. And of course, psychotherapy is always encouraged in mental health. But the way that it works right now, especially in community settings, is that the person who gives you your medication is a psychiatrist or a nurse practitioner, and the person who talks with you is usually a psychologist or a social worker, and hopefully they talk to one another from time to time to coordinate your care. What kind of different things are done is not really well integrated. The opportunity of psychedelic-assisted psychotherapy is true integration. There's a lot of work that gets done. It's not just, here, take this pill, you'll feel better. It's really about, first of all, the preparation of what the work is going to be like, developing the relationship so that that work can happen, providing education about how trauma lives in our bodies. And the fact is that things that we may not expect to be traumatic are sometimes uncovered as really powerful secrets that have been in there. Really preparing somebody to confront something inside of them. Doing the work, which is when you administer the psychedelic and have the therapists there kind of to bring out the material and then talk about it a lot afterwards, the integration. So I think, again, the idea, I mean, an 8-hour session is just something that I never heard of before. I mean, I'd been in mental health, 3 decades, and the idea that a patient would talk for 8 hours with 2 therapists on their side, what is that? But once you've done it, you understand that there's no other way. And I've had I suggested to someone that it's kind of like having a baby. You know, trauma work can be like that, where you're trying to really get towards an end. And no one tells a pregnant woman after a few contractions, you know, our time is up, come back next week, we'll do some more. You know, this is a process where the doctor and the labor team is with you for as long as it takes, and through a process that is sometimes easy and sometimes difficult, that requires a certain kind of support. And everyone knows what they're doing in that labor room, even though the woman's doing the work. And it's very much like that. And once the work is done, you have a baby. You have something that is very tangible. There's still work to do. You got to raise the baby, but you've done a unit of work that really feels like a unit of work that couldn't really be accomplished in a different way. And that is what I learned from the experience, that trauma work isn't really about very small units of work. It's not about directing someone to think about a certain trauma. And to me, it feels like it should be a more organic process, where if you prepare a person to be in the best state, which is trusting, empathic, getting rid of the self-loathing or the judgment or the fear or the need to run away from what we run away from sometimes. And they're in a room where there's maximum safety and you're not rushing them. You can accomplish a very important kind of resolution of a terrible trauma, and not get rid of the trauma. You don't get rid of the trauma, but you make space for it, just the opposite. You allow it to become part of you, and you then begin a process of integration and growth. And this is not the way that people talk about how to heal from trauma in medical schools and graduate schools. And it is a very important way that we have to be able to have conversations with people who are trauma exposed, and possibly even people that have other conditions in which a traumatic experience lies at the core of it.
So I've heard you speak about 2 things that I'd love you to mention to people. So the scope of just economic cost. Obviously the human cost is infinite. But just the economic cost, as well as describing to people sort of what treatment resistant means, because you're not talking about people where, you know, that they just, their score was such that they registered as PTSD. You're dealing with a more challenged population who's really suffering. So could you comment on either or both of those?
Well, the cost of PTSD to society is really very great. And there have been a lot of articles that have really talked about it, the cost in terms of not being able to work and not be productive, and the cost of going to treatment for years or decades. I mean, those costs are pretty obvious. In the VA system, they actually have statistics on the cost of mental health, the cost of care for veterans. The VA budget itself, last I checked, was over $200 billion. It's a very intricate healthcare system. $9 billion are spent on mental health. Several $billion are spent on disability benefits, so of which PTSD is the third largest contributor. About half a million cases of disabled veterans are added each year. So not half a million dollars in disability is added each year. So it's expensive. And to people who are not working, there's a cost of whatever it was somebody would have been doing that they're not doing. So I think that having something that would be able to fix a problem in a way that begins a process where somebody feels able and in control, being able to function, being able to be a functioning member of their family, being able to have a fuller life. I mean, that's the dream. And many people in the field have been working towards that dream for a really long time. Yeah, so that's that question. And treatment resistant was the second question. So that's just a word, that's used in our field. And it's a word that means that you tried something that was prescribed. You tried a 12-week course of cognitive behavioral therapy. You went on antidepressants for a period of time, but you didn't get much better. You might have gotten a little better. Most people get a little better when they start therapy, but that your general status in life hasn't changed. I don't like the term treatment resistant, though I use it because other people do, because, I don't know if it doesn't seem to implicate the treatment, right? It seems to implicate the person that received the treatment who's resistant to its effects. But the idea, I think what most people who have been studying PTSD for a long time know is that there are many different approaches to treating PTSD, and they all work on some people. But there isn't really an approach right now where you can confidently say this treatment will work on absolutely everybody that has PTSD. Now, before I began to immerse myself in this psychedelic psychotherapy work, my concept was we could use biologic methods to figure out people's core molecular biology and match them to the appropriate treatment if we understand what that treatment does to core molecular biology. And that's what I've been chasing for at least 15 years. So the idea is we can learn about individual differences either from the epigenetic profile or from the brain profile or some kind of biologic signal. We match that up with the signal of recovery for, let's say, antidepressants or behavioral treatments. And then we have some profile where instead of trial and error, or the luck of what therapist you go to is the treatment that you get. If it's an EMDR practitioner, you get that, something like that. We could have a more scientific approach, as they do in cancer. You don't just treat every tumor the same way. And so I've been very invested in using very similar strategies of molecular biology towards a personalized medicine approach. So again, the MDMA data look very good, look better than other therapies have looked. But again, you have to test it in a very wide segment of the population, including where it hasn't been allowed to be tested yet. So we got to do that. And then we have to learn from it. We have to learn about why it worked, how it worked, and then see, how we can really carry it forward and make sure that it's available to people who will benefit from it the best.
Thank you on that. I'm going to ask one last question, and then there are a lot of questions from the audience, but I just wanted to make one comment first, that in with all the economic costs of billions of dollars, it's the human costs, the destroyed families, the destroyed lives, and the frightening statistic of approximately 20 to 22 veterans every day taking their lives through suicide, which means that every year we are losing more veterans to suicide than we have in all of the conflicts that we've been involved with since September 11th. So it's just astounding. The last question I wanted to ask was, can you talk a little bit more about the center that you're leading at Mount Sinai? This is really just the beginning for your center, and you've got a lot of exciting programs that I'd love you to just take a moment sharing with people on the phone.
Sure. There are 4 major goals of the center. It's called the Center for Psychedelics, Psychotherapy, and Trauma. There's a lot of excitement at Mount Sinai about it. They're being incredibly supportive. And there are 4 goals. The first is, of course, to do clinical trials. And we're going to start with MDMA-assisted psychotherapy. And we're going to start with a protocol for veterans, hopefully drawn from the VA, and hopefully at the VA. We're working very hard towards that. The second goal of the center is training and education. As I mentioned, I think it's really important to be able to have an accessible way of exposing therapists of every discipline to what it means to work with psychedelic-assisted psychotherapy. So that's very important, and we are going to have at least an elective for the psychiatry residents at Mount Sinai. I'm very excited about that. We also would like to try to figure out ways of having protocols where therapists can be exposed to what it means to be in an altered state, and we're really working hard on figuring out how we might go about doing that. The third is, of course, the biological and translational studies. We are very well positioned to take the neuroscience a few steps forward, both in terms of understanding what the effects of psychedelic psychotherapy might be on various biologic underpinnings of trauma and PTSD, and really kind of developing an idea of who might best be served. And, you know, we might learn who should not be served by this, but we have to learn about it. And we have to learn about it responsibly, and bringing to bear all the tools that we have been able to amass in the last 10 years to really do this right, so that it works as well for trauma survivors as it works for cancer patients right now. That's the third aim. The fourth aim is that there really is a need to have academic centers that are interested in psychedelic psychotherapy get together in some way, some sort of a consortium, whether formal or informal, because there is strength in numbers. And the zeitgeist has really told us for so long in psychiatry that psychedelics might be harmful. There's a lot of caution. And to have leadership come from academic institutions, especially very credible, high-profile ones like MGH, like Mount Sinai, like Yale, like Stanford, like UCSF. I mean, this is very good for the field, and Hopkins. If we're all talking to each other in some way and working together, there might be a way of really bringing a generation of science to the public in a short period of time. And the template for this initiative is the PTSD Genomics Consortium, where everybody in the world who was doing any PTSD research got together and pooled their blood samples so that genes of risk for PTSD could be identified. It took really a global effort of everybody working together, because in order to identify risk genes, you need samples in the thousands. So the idea sometimes of working together is often left off the table. It's very hard. Everyone's busy doing their own thing. But the idea of bringing people together from all over the world that are taking this very seriously is the fourth mission of our center.
Which is an amazing organization under an incredible person's leadership. So thank you.
We're just getting started. So we hope.
Involved in growing it, and anybody interested in that is certainly, if you reach out to me, I'll connect you with Rachel on that. Very, very worthwhile to be involved with and supporting. Yes, there are a number of questions. We are in a unique and challenging moment for mental health. Can you share any perspective on the potential impact of the COVID pandemic and social distancing on mental health? This says in America, but we have people from all over the world listening, so in America. By the way, there are over 300 people who have registered to be joining. People are really, really interested in this area and in particular what you're having to say, so thank you.
Thank you. Look, it does not take too much expertise to figure out that that there are negative mental health implications of this coronavirus, especially on the more vulnerable people. In a way, it gives some people a pause from a very hectic life, but it also increases isolation, increases access to mental health more generally, except through telehealth, which isn't everybody's cup of tea. There's economic devastation. I mean, there's no question that this is going to have a large mental health impact. In fact, there are predictions that the rate of suicide will go up dramatically. So I think now more than ever, there is a need to make sure that we have every single weapon in our arsenal and build systems of availability to mental health treatments. I mean, that's a no-brainer. I do want to say, and I am asked about this a lot when I'm interviewed, I think as things get better, a lot of the ways that people are feeling will change. For the majority of people, once they kind of find their footing again, most people will concentrate on the here and now, and a lot of the struggles will be remembered as struggles in the past and won't necessarily be carried forward. But for a significant percent of the population, they may hold on to some of the really traumatic moments that these last few months have brought us.
One of the positive silver linings out of this, very difficult situation is this tremendously increased focus on mental health and awareness of that as an issue, so that, hopefully will lead to better ways of ameliorating some of the ongoing and potential future suffering. Rachel mentioned that often the trauma that is causing problems is not obvious and may not even be remembered by the person as trauma to the individual. How do you think MDMA and other psychedelic therapies could be used to achieve potentially broader mental health benefits for individuals whose symptoms are not as extreme as those who would qualify as having DSM-5 PTSD?
Yeah, that's like that's a really good question. I think that the reason that this is a very good question. I think that part of the fact that I was able to have an experience as somebody that doesn't have PTSD, and obviously by the time you get to a certain age, you've had life experiences that could be counted as traumatic. But the awareness of the kind of things that were in my subconscious, I don't know, in my altered state of consciousness, the kind of things that came to the surface were not things that I could have predicted were important. And it's not so much that you don't know the trauma that happened to you. You might know that, for example, you were in combat, but what you might have forgotten about was a tremendous indignity when you were younger of being bullied, and how that made you feel that you need to be invincible, and how that feeling of invincibility was really challenged. So you might need to connect back to something earlier than the event you think is causing the problem. Obviously, many people could benefit from something like this. I think that with psychedelics, people talk a lot about intention. But for right now, I think that the focus that I have is trauma and training of therapists. It is a tremendous, it's a tremendous challenge to try to have a therapist understand what working in an altered state with someone is if they're not familiar with what that is. And so I think that So that's a challenge. We have to rise up to that challenge and figure out methods that are safe, legal, okay, valid, that make people feel that they're doing the right thing and not that they're potentially risking something. We have to figure out ways to get this right.
Another question. How are you studying the epigenetic markers of PTSD and trauma? And what are they, sort of in non-science terms for those of us who, but also, have there been any changes in these epigenetic profiles with MDMA treatment? And is this something that you may be looking at in the future?
Yes. So the way that you, it's really easy to look at epigenetic markers, surprisingly. Now that we know what we're looking for, you basically are looking for a certain molecule that is an epigenetic mark. We look at methylation, which is a carbon with 3 hydrogens, and you decide where you want to look at it in a gene, in the nucleus of the cell. I started out by wanting to look at epigenetic marks in specific stress-related genes that had already been implicated in trauma. But these days, you can look at really the whole genome, and you can do a scan of looking at epigenetic marks on many, many different locations of many, many, many genes, and then use computational neuroscience to figure out what you've learned. And that's what we do. And we have done this for other treatments. I believe there's a study that is underway, which I'm actually part of, where saliva samples are being collected in the context of a MAPS phase 3 trials. And they have not been analyzed yet, but hopefully they will be informative. There are methods of doing this in blood. There are methods of looking at this in the neuronal cells. So it's something that can be done. It just is something that requires large samples and, some lab resources, but that's the benefit of doing this work in a consortium. Imagine if everybody who was doing a clinical trial could pull together their clinical before and after samples. Well, that we would learn a lot from doing that kind of an effort.
Yeah, and many of the people, some of the people on this webinar are involved with differing institutions. So, I would just encourage everyone to. You're so right. You're so right.
Because you're not going to learn that much from, my studies have been a problem because they've been beautifully designed, but how many people can you treat in one study? So the idea is, especially if you're looking at a lot of genes, you need a lot of people to be in those studies. And so the roadmap for getting this knowledge is absolutely there. It doesn't have to be innovated, it's there. And it's just a matter of having a lot of people treated with psychedelics and having the people that are treating them wanting to work together so that we can all learn this.
Thank you. Another question, and I'm not sure, well, I'll ask it, and I'm not sure how familiar. Can you speak to the potential of ketamine-assisted psychotherapies, which could be currently available as a treatment modality, and also as a comparison to MDMA-assisted psychotherapies?
Boy, somebody has been in my Zoom. I've been having a lot of meetings about that lately. Mount Sinai was a very early adopter of ketamine. They've been at the forefront of bringing ketamine to its current status as a legal medicine for depression. And they're very interested in ketamine for PTSD. They have not really embarked on the ketamine-assisted psychotherapy studies, but now we are in discussion with designing them. It's very different. In ketamine, the state that you're in ketamine is less conducive to having the kind of therapeutic relationship while you're in the state. It's more, it would be more akin to psilocybin of really kind of being in a different place or dissociating or being out of body. So it isn't the same thing, but it should be examined. The question that we're going to be asking is whether doing psychotherapy, a course of very intensive kind of psychotherapy, after maybe 5 days of ketamine will prolong the effects of ketamine and make you not have to go back as quick. That's one of the problems with ketamine, that it wears off. So it does provide a very good therapeutic relief. It's probably fantastic for somebody who's very suicidal or depressed, but it doesn't seem to have the same kind of enduring transformational potential as is being described in the MDMA trials. But it's worth thinking about all of this stuff. And that is something that we are doing actively at Mount Sinai, really trying to figure out what the best design would be and how to go forward with it.
Thanks. Could you comment on the potential cost-benefit analysis when you are looking at an 8-hour session and therapy before and after? Are there long-term potential benefits that can cost justify some of this, in addition to the human?
I get asked this question a lot. It is an initial cost, but it's like going to a surgeon. We don't ask that question when a surgeon is charging us, I don't know, $20,000 to remove something that shouldn't be in our bodies. Of course, it would be much cheaper if we could just go visit that surgeon every week for maybe, 5 or 6 years. But that's not the model. The model is that some things require an upfront cost because the work that has to be done is intensive. And you don't want to skimp on it because you want good therapists and you want to pay for their time and expertise. But you also want to know that at the end of it, you have fixed a problem. You have come, just like when you go to a surgeon. Sometimes, you have a negative outcome with a surgeon, you have to go back and get it fixed. I mean, there are no promises here. But I think the upfront investment versus decades of symptoms is something that is easy to understand. I think what people struggle with the cost is so many of our mental health patients, kind of their insurance runs out and they don't do anything, so it doesn't cost anything. But they're symptomatic. They need the care. So I think that it is something that we're going to have to figure out in terms of the cost, crunching the numbers and the cost-benefit analysis. But I think the first thing is to really make sure that this can work for the most intransigent PTSD cases that there are out there. And then we have to be able to figure out ways of changing people's lives with it.
Great, thank you. And yeah, I mean, as business people, you often make an upfront investment for long-term, again, just looking at it from a number standpoint, significant cost savings, both in terms of benefits, in terms of treatment, and in terms of productive members of society. So, I've seen other things that indicate that there could be huge ROI, to use a business term.
I mean, I'm wondering if one day we will use the metaphor of kidney and dialysis, getting a new kidney, the cost of that versus the cost of dialysis. I'm wondering, I mean, we're at a stage now where, I want to make sure that I convey that I'm so excited and enthusiastic, but I also think that so much more work is needed that we have to do. When that work is done and we really know what's happening, those are the metaphors that we will use. And those are the metaphors that will be very, very powerful in terms of the costs.
So unfortunately it had to be the last question, and then there were some, but can you please talk more about generational trauma, how that trauma's passed the next generation, and just what that really means?
Yes, I can. I think that what we're usually in 30 seconds, I can do anything. But what that tends to refer to is the fact that sometimes people feel that they are affected by events that occurred in prior generations. In the case of Holocaust offspring, they came for treatment really feeling that they carry the burdens. At first they thought maybe of their parents' symptoms, but the studies of intergenerational trauma really refer to this idea that if there is an effect of trauma that is encoded as an epigenetic change in a gene, then when that cell containing that gene divides, the epigenetic mark is in both daughter cells. That's in mitosis, you create two daughter cells from a single parent cell. But the gene can also survive in the case where a cell splits into sperm or oocyte, a precursor of egg. And so there is a potential mechanism to have traumatic effects be passed to the next generation. There are also exposures during pregnancy that can affect the in uterine environment and be transmitted to offspring fetuses in utero as a result of maternal stress. And of course, we all know that how we raise children early in life can have profound epigenetic effects that also alter the course of their lives and their stress response systems. So there are lots of different ways to affect change. Being a parent is a big responsibility. And the science is very exciting about some of these mechanisms. And, you know, we could spend an entire session just on that topic.
Great. Well, maybe at some point you would join us for a session that we will do on that. So all of us are deeply grateful to you for your time today and the incredible work you're doing. Thank you so much.
Yeah, pleasure.
I want to let people know that our next global conference call, we're taking a break for the summer, but that will be Tuesday, September 15th at the same time. And our guest will be Dr. Julie Holland, who's a psychiatrist specializing in psychopharmacology with a private practice in New York. Dr. Holland was in charge of Bellevue Hospital Psychiatric Emergency Room over weekends from 1996 to 2005, and she's a medical monitor on the MAP studies. And she has a new book out, Good Chemistry, which explores how she thinks about psychedelic drugs and how they might be able to be more widely used to make treatments more efficient. And the book explores the science of connection, why we need it, how we lost it, and how we might find it again. So I invite people to that. You'll be getting a note about that. I want to know that recordings of calls are generally available to all registrants. So sign up even if you aren't able, even if you're not sure that the date will work for you or there's a time conflict, and that way you'll get it. And finally, I want to encourage YPOers who are not yet in the psychedelic medicine for mental health group to join, and a few people have written in the chat that they would be interested in, you know, the for action or microforums or otherwise getting involved. So again, Rachel, thank you so much. Deeply grateful, and everyone, to you and everyone, have a great summer, stay safe, and thank you for all you are doing.
Thank you.